In this video, we'll be learning about pathological calcification. The learning objectives for this video are to learn the definition of pathological calcification and to know examples of tissues and devices that are susceptible to pathological calcification. We've previously discussed the appropriateness of the host response, which is important because what is appropriate depends on the implant site and the nature of the material. And that's because some reactions may be acceptable for one application or one site, but not for another. And implant calcification is perhaps the best example of this idea. Particularly, a great example is the contrast between an orthopedic implant versus a heart valve. So in the case of a bone graft, where you're trying to repair a fracture, such as this one shown in the femur here, calcification is a good thing. You have to have that calcification to get healing over time and union of those bone fragments. But if we look at a heart valve, calcification is very bad. So on the left, this is an uncalcified valve. So that's what it should look like. And then on the right, we have a calcified valve. And you can see here that it looks very crusty and very brittle. And so that is really going to fail. It's not going to function very well. So calcification is very bad in this scenario. So we would say that calcification is pathological. But calcification is really kind of non-specific. So what we're really talking about is calcium phosphate deposition. And so we learned about calcium phosphates before when we were learning about ceramic biomaterials. And in our body, the predominant calcium phosphate is hydroxyapatite. Technically, it's a substituted hydroxyapatite, but for here, we'll just simplify and say it's a hydroxyapatite. So this is your chemical formula here of pure hydroxyapatite. And the reason we have hydroxyapatite in our bodies, and that's the mineral component in our bones and teeth, is because of its thermodynamic stability. So if we look here on our solubility isotherms, which I know you probably all hoped you wouldn't see again, but here at about physiologic pH, maybe it's a little more up there, hydroxyapatite is the least soluble, meaning it's the most stable thermodynamically calcium phosphate mineral. And so what that means is that hydroxyapatite wants to form in our bodies. So that's very important. But we have to have the necessary building blocks to make the hydroxyapatite. We'll come back to that in a second. But now let's consider some normal scenarios where we have calcification. So of course, bone is an obvious one. So bone has a really beautiful hierarchical structure where you can, we're going to consider it from the nano to the macro scale. Starting at the macro scale, if we look at our anatomy, so we have cortical bone on the outside of our long bones here, and then in that cortical bone, so if we kind of zoom in from here, the individual subunits of that bone are called osteons. And then these osteons, they look like little tubes with concentric circles, right? But then there's a hollow canal in the middle called this haversian canal. And then the concentric circles around it, they're actually, they're referred to as lamella, but in each lamella, so there are aligned collagen fibers. So that's what these lines signify. And that orientation of the collagen fibers changes in each lamella. And that's important because that's what gives bone its really good mechanical properties. And then within each lamella, those collagen fibers, so they're bundles of collagen fibrils, but the collagen fibrils themselves are mineralized. So we have these bone crystals here, and these are made of hydroxyapatite. So now if we look at it a little bit more at this mineralization, right? So this collagen fibril, it's made up of individual collagen molecules, and you can see they kind of stack and align, but there are gaps, and these gaps are known as these hole zones. And these are really important because the hydroxyapatite, those bone mineral crystals, which are nanoscale, size here, they preferentially form there. So what I want you to take away from this is that collagen provides a template for calcification. And then, as I mentioned before, it's not pure hydroxyapatite, it's a substituted hydroxyapatite. So that we actually have carbonate substitutions for the phosphates, and in some cases also the hydroxide anions, but that's not as important here. So it's hydroxyapatite, and then collagen provides a template for the calcification. So these whole zones, they serve to kind of nucleate that calcium phosphate crystal formation. This also happens in our teeth, of course. It looks a little bit different. So here we have a cross-section of a tooth over here. And you know, on the outside, we have enamel, which is really highly calcified. But then on the inside, we have dentin, which is also, it's not as calcified as enamel. But anyhow, structurally, it's pretty similar to our bone. So we have these little tubule-like structures, and then they're composed of this mineralized collagen fibrils. And the collagen fibers, they have a little bit different orientation, but again, you see we have hydroxyapatite, so abbreviated HAP here, but this is hydroxyapatite crystals that form in the gaps between the collagen fibers. And so again, collagen provides a template for this calcification process. But as I said a couple of slides ago, you know, hydroxyapatite wants to form, but we have to have all of the building blocks necessary. So our body has plenty of calcium. So we have, I believe it's roughly 10 milligrams per deciliter of calcium in our blood, in our serum. We also, of course, have lots of hydroxide anions because we have so much water in our bodies. But what we don't have a lot of is phosphate. And that's a good thing, because if we had enough phosphate, then we would just spontaneously calcify all over our bodies, which would, of course, be terrible. One of the enzymes that plays a critical role in regulating phosphate concentrations and preventing that is alkaline phosphatase. So alkaline phosphatase converts pyrophosphate into inorganic phosphate ions. So pyrophosphate is essentially just two of these phosphate anions. So alkaline phosphatase, this enzyme, is present in all tissues, but concentrations are particularly high in the bone and also in the liver. So if you ever go to the doctor and you get a blood panel done during like an annual checkup, you'll probably see they measure alkaline phosphatase levels as a metric for liver health. But in the cells, alkaline phosphatase is localized to the cell membranes. So we've got two cartoon illustrations here to show you that. So in these cartoons, alkaline phosphatase is actually abbreviated as TNAP, which stands for tissue non-specific alkaline phosphatase. So recall I said it's present in all tissues, so hence the name. But here we can see that it's localized in this. So this is an osteoblast. It's localized into the cell membrane, and then it plays a role in converting. So this is your pyrophosphate here. Gets converted by the TNAP to 2 phosphate ions. So then we have all the building blocks. So we have calcium, we have phosphate, hydroxide anions aren't shown, but then we get lots of hydroxyapatite mineral that can form here. So these concentrations are really high in bone cells, but we also have them in our cardiovascular system too. So here this is showing vascular smooth muscle cells, and you know the enzyme here, it's really faint, so indicating that there's not as much of it there, but it is there, and it serves the same purpose. It converts pyrophosphate to phosphate ions, and then that gives us the building blocks we need for hydroxyapatite. So this is why we can get pathological calcification in other tissues. So some examples of natural tissues or tissues in our body that can have this pathological calcification are arteries, heart valves, which are shown down here. So here you can see this is calcified on the right. There's also calcification of the placenta that can occur, and then ankylosing spondylitis is another example. So that's an inflammatory disease where the vertebrae of your spine can actually fuse together because of this pathological calcification. So based on those examples, we can kind of glean that pathological calcification is simply the undesired formation of nodules of calcium phosphate within a tissue. And this is not restricted to natural tissues. So this can also happen with biomaterials that are implanted in the body. So we can get calcium phosphate formation on the surface or within implanted materials. This has been observed to happen with cardiac valves, cardiac assist devices, and that's because exposure to blood, there's lots of calcium there, and then also with the mechanical stresses, they're going to be particularly susceptible. It's also been observed, though, with urinary prostheses, so catheters, and soft contact lenses. And what's really important to take away, again, is that this calcification, it results in embrittlement of these devices. And that embrittlement is going to compromise their mechanical integrity and result in premature failure of the device. So down at the bottom, we just have a couple of definitions here. So specifying that mineralization is just non-specific deposition of inorganic material, where calcification specifically, which is what happens in our bodies, is a subset of this where we're getting calcium phosphate mineral deposition. So when it comes to implants, though, pathological calcification is found with both synthetic and natural-based materials. But natural materials that are treated with glutaraldehyde or formaldehyde, which are fixatives, are particularly susceptible to pathological calcification. Now, the extent of pathological calcification is going to depend on the structure and the chemistry of the biomaterial, particularly the presence of nucleation sites. So that plays a role in why natural materials are susceptible. So recall I said that collagen naturally templates mineralization in our bodies. So they can collagen can provide nucleation sites, but also those enzymes are important as well, and those can be present in residual concentrations in natural materials. So that's very important. Also, host metabolic factors play a role. So down here at the bottom, we have this example of younger patients could be more or likely to be more susceptible to pathological calcification because of their metabolism. They're growing, so that the environment in their body is going to favor mineralization. The mechanical environment of the implant also plays a role, as I said on the last slide, which is why the cardiovascular devices are particularly susceptible there. But now that concludes this video. In the next video, we're going to talk about the mechanism by which these natural materials can calcify pathologically. We'll also talk about strategies to mitigate their calcification and testing methods to assess calcification.